Good morning. Welcome to the first breakfast panel discussion for the mHealth Summit, Empowering the Physician in the Era of Patient-Directed Healthcare. My name's Eric Wicklund. I'm editor of mHIMSS.org, and we've brought together three very knowledgeable people from very divergent parts of the country to talk about how we can get the physician interested in mHealth tools and services. Physicians are normally rather reluctant to take on something that they consider to be new. So you didn't pay to hear me talk, so I'm just going to cede the podium here to Andrew Watson, who's going to be our moderator today. We also have Orlando Portali from Palomar Health and Mark Probst from Intermountain Healthcare. So, Andrew.
Thank you, Eric. Thank you, Eric. And the good part is there's no slides this morning, we've learned, which is excellent. And this is going to be a very casual conversation over the course of the next hour or so, and to discuss the power of mHealth and what we're seeing in the transformation of healthcare, and especially in patient-directed healthcare. And I'll have Eric Portali and Mark Probst both introduce themselves, and then I'll introduce myself. And then from there, what we want to do is to go through what Eric has laid out and what we're looking at here, which is empowering the physician in the era of patient-directed healthcare. And I would just like to say, as an actively practicing surgeon, that I always want to make sure that I use the term provider as well, because I find that the nursing community is also a very powerful tool in the world of healthcare. And to be honest, they run my practice, run my life, take care of my patients, and I just do the yard work in the OR once a week. So it's a very interesting perspective. But why don't we start with the speakers introducing themselves, and then I want to have an open conversation with the audience and work our way through this. And at any point, obviously this is casual, we'll be speaking from down there. Feel free to raise your hand, ask some questions, and we'll try to keep this as apolitical as possible because we come from different parts of the country. And looking at the electoral map, I think our states will color differently.
Looking at me, you know?
No, I'm not. It's just a more of a broad glance. So, Mark, why don't we start with you?
There you go. Good morning. My name's Mark Probst. I'm the Chief Information Officer at Intermountain Healthcare. We're located in Salt Lake City, Utah. We consist of about 23 hospitals, 150 clinics, 1,000 employed physicians. We have a little health plan. We about 500,000 members, growing quite a bit as we look at Medicare Advantage and other areas that we're getting into. We've built a lot of our systems historically. Our electronic medical record was self-developed by a cardiologist by the name of Dr. Homer Warner, who some of you may be aware of, and Homer unfortunately passed away just last week. But we've had the tremendous experience of relating to him and learning from him about things you can do with data, not just information systems, but data. And I can tell you, it pervades everything we do in information systems. We start at the basis of the data and what it can be used for and do, and then we move that out to what applications and things that we can do. That's also had an impact on the things we have begun to do in this area of mHealth, whether that's telemedicine, which we really only got involved in about 1.5 years ago, but did in a very real manner. We hired some tremendous talent and have put a lot of energy and money into developing applications and tools that would support telehealth. Clearly the application space, so the apps and the mobiles and the handhelds and the iPads and the BYOD is all things see, I got all those acronyms down in. But we've had to deal with all of these things. But again, as we talk, you'll probably hear a consistent theme. It's about the data, and it's about what that data can do to really either improve a process or dramatically reduce the cost of that process. So it's a pleasure to be here, and look forward to the conversation.
Good morning, Orlando Portali. I'm the Chief Innovation Officer, not the Information Officer, at Palomar Health in San Diego. I was going to turn off my cell phone, but I realize it's like 4:30 in the morning back there, so I don't think anybody's going to be calling me right now. We also do a lot of our own internal software engineering and development work, and have done so in the mobile space since around the fall of 2010. And in the fall of 2010, we kicked off a software development effort to build our own mobile computing platform from the ground up, as well as purpose-built applications for physicians to use on their smartphones and tablets. You may have read that we recently licensed our intellectual property over to Airstrip Technologies. I see my old friend Alan Portella, not to be confused with Portali, is sitting here from Airstrip. He wants to make sure I don't say anything out of line here in terms of his products. I hope you're not a user of Airstrip, are you? So anyway, and we've been innovating since then in a number of other areas, building applications for direct use by patients, as well as doing some work with sensor-based physiological monitoring systems and mobilizing those as well. So there's a number of topics we can talk about here. I would like to get a read in terms of the audience mix here, and then we can maybe frame some of our remarks. How many are from the, we'll call it sort of the vendor world, products, services, consulting? Okay, I used to be in that world. All right, the hospital side, health systems, okay, and the evil empire, the payers. There you go. I used to, hey, well, I worked for WellPoint in a previous life, so I feel I understand where you're coming from. Okay, well, that I think that helps us in terms of framing some of the. I don't want to take over the discussion. Go ahead. Did you come with a list of questions? Because we could just take over the. Okay, no, go ahead.
It's fairly open source, no worries. And one last question, actually, for the audience: how many nurses and doctors are in the room? Excellent. Okay, because the provider side. And just as a quick introduction to myself, I am an actively practicing colorectal surgeon, so if they misbehave, we have ways of retaliating. But I'm only about 10% clinically active, and I'm 90% the corporate side of the University of Pittsburgh Medical Center. And we are a $10 billion integrated system like Intermountain in Pittsburgh, Pennsylvania. And we, too, have 21 hospitals, 3,000 doctors, and have 1.9 million people in our health plan. And we have an amazing situation going on with insurance right now in Pittsburgh. If you're not familiar with it, I would advise everybody to watch what's going on between a $14 billion insurer, Highmark, and the University of Pittsburgh Medical Center, which is $10 billion. And I think that after healthcare reform, this is one of the most interesting proverbial canaries in the coal mine in healthcare. Can an insurance company help to steer a market by purchasing hospitals? I'm not picking sides, but that's the essence of what's actually going on right now. And it's a fascinating, fascinating discussion and situation that's going on. And the other part of what I do is I help to run telemedicine for UPMC and work for an organization called the Center for Connected Medicine. And I'm glad that Eric has invited us here on behalf of the center. And we represent about $510 billion of companies, and it's an executive briefing center in Pittsburgh. And we've been open since 2009, had almost 15,000 people come through from 58 countries. And that's connectedmed.org. So it's an interesting perspective that we have from very large integrated systems, very successful systems. We have innovation, information, provider. And so the world of mHealth and the concept of mHealth, I think we should start with that and talk about what mPower means. And I want to go through the three objectives and start with, if you engage providers, nurses, and doctors with mHealth, or if you want to empower them, what does mPower actually mean? And so I want to throw that out up front with how would you define mPower, because you'll frequently see in the world of healthcare enormous amounts of technology, certainly in mHealth. We see it all around us. You see it in the consumer electronics market. You'll see it at the American Telemedicine Association. But I also think it's important to define exactly what this technology is going to do for us or how it's going to empower us. So I want to start with that, and I'll start with Orlando. If you were to define empower, how would that look like?
So let's talk about the physician first. Now, you talked about your own organization and some of the challenges that you're having from a regulatory standpoint in terms of being a payer in the market as well and competing in that space. I think the legislation is going to drive organizations toward taking on more risks. So standalone hospital organizations that haven't been in the risk pool, if you will, and involved on that side of the business are going to start to look at a a lot of the core care coordination processes that we have in health insurance companies and start to bring those in-house in hospital organizations. As we do that and look at capturing covered lives across the medical service area, we're really going to need to reach out to physicians in a much more proactive way. And we have been addressing the issue and by developing some mobile apps that cut across organizational boundaries that are horizontal, if you will. You know, today a lot of hospital organizations have spent a lot of money on vertical integration. The electronic filing cabinet, these multi-million-dollar Epic projects that look at capturing information within a certain organization, a specific organization, and capture that information and lock it up in an Epic system, for example. What we're going to need to do in the future is to cut across organizational boundaries and be able to pull information together for the physician in real time that's collected among various disparate EMRs. And I think mobility is an enabler for that.
Interesting.
Well, so mPower. I think that as we look at some of the problems or the challenges that exist, clearly empowering the patient to take better care of themselves. And as we look at the new economy that's coming in healthcare, we need those patients to stay healthy because that's the way reimbursement's going to happen. That's the way we're going to get paid. And it seems to me with electronic medical records, with everything we've kind of done to date, particularly with the government's help, if that's a term that you can use, the government's involvement, we've done just about everything we can. Is this actually working, or am I just talking to it around you? Okay. We've done everything we can to disempower or disengage the patient and the physician and the nursing care and all the care teams. We've made it so difficult for us to share data across those various constituents in the process of care. And we've really made it hard. And that what empowering should be able to do, particularly with the new knowledge that we have around security and how we actually can keep data private. The fact that we can do these very specific kind of applications to solve a specific problem so that we're not just, when we try to solve a problem with healthcare IT, we don't try and solve that problem. We try to solve every problem in the world or any instance of thing that might occur. And with some of the new technologies that exist today, we don't have to do that. We can actually solve problems. So it's certainly empowering that whole chain of care. Also, the concept of empower to me is, wow, you IT guys, you're not the people with all the good ideas on how to provide clinical care. That actually those really good ideas may exist in a nurse, may exist in a physician, may exist in a completely ancillary part of the organization, but we're figuring out ways to empower them to get their ideas, to quickly turn those ideas into something that might have value, and then go through the process of creating something that does have value. So those would be some thoughts I had around mPower.
So can I just...
Absolutely.
Go back and go get a pie.
So you... It's going to be a long day, isn't it? So you bring up a good point. Some of the least innovative departments, if you will, organizational roles in hospitals, is the CIO and the IT department. How's that for a slam? But you're right. That, CEOs have looked to, yeah.
I'm staying out of this one.
Have looked at, we're just getting started, have looked to IT departments to innovate when they should be looking at their leadership team to innovate in each of the service lines in the business and clinical areas. And that's one of the things that I do. I'm the equal opportunity disruptor, if you will. So, my role is to drive innovation across the organization, not just in IT. Many of the things I do have an IT dependency. I look over here, and there's our CIO there grimacing right there. That's Paul Peabody, Palomar's CIO. He's like, oh, no, he just called me non-innovative. It's the abuse you have to take sometime. But especially in this space where we're talking about care coordination now, across the medical service area, dealing with physicians in the community, bringing them into the fold, linking up with independent physician practices across the service area, all those sort of efforts to reach out into the community for dealing with covered lives, transitions of care, and the issue of addressing appropriate transitions of care using mobile technology as well as an enabler. All those things should be driven by the lines of business, the clinical service areas, and then IT should just be there to basically provide the back-end support that's required.
So when you got that, so when you got that title, did you have to like buy a vowel?
Interesting. When you see where healthcare has come, that I come from a family of surgeons, and I'm actually the fourth generation surgeon, and I look at my own family that healthcare with my great-grandfather was done at the home and in the community, and healthcare now was done in the hospital. And it's the 95% problem that we're facing, that 95% of the time our customers are at home or work, and we just don't offer our product at home or work. So we have a little problem here. And as you'd say, there might be some good collaboration opportunities with our customers. And when people look at the culture of healthcare in the United States, and it's based with hospitals and used to be a very doctor-centric healthcare model, this is obviously gone and over, and it's effectively smoldering right now, which is okay. It's been the natural evolution. And what's fascinating about when you talk about mPower, mPower isn't a hospital's HIT infrastructure, and it's not a collection of nurses and doctors. If you look around us and look at even the sponsors of this symposium, that it's the consumer electronics market, and there's no one that's going to get in the way of Google, Verizon, Apple, so on and so forth. So it's here, it's coming, it'll evolve, and it's going to be an organic grassroots approach. And so when you talk about mPower, what I hear you gentlemen saying is one is about data and ideas. I think the data is critical, and it's a two-way data portal too, patient and provider. And it's also about care coordination and bearing risk. And for the first time, doctors and hospitals are bearing risk in healthcare, and it's a very uncomfortable situation. So one of the objectives here is to talk about the barriers to adoption. And I'll tell you that as doctors and hospitals bear risk, that barrier of adoption will start to fall, because this is the natural evolution of healthcare. So I want to throw something out to the two of you to be very specific here and tangible, that if you start with 1995 and work forward, there have been two transformations of healthcare right under our noses, and our collective nose, and that would be laparoscopy and EHRs. So we took a generation of proceduralists and told them to use chopsticks, video cameras, needles, wires, and ultrasounds instead of scalpels and then retractors. And if you look at the impact on healthcare, it's now mainstream. That took about 12 years. Started with the lap chole, lap colon, and now it's everything from intracranial surgery to thoracic surgery. Beside me on Fridays, they're doing laparoscopic liver resections. They're going home in 2 days versus 14 days. So that one worked. And the one that's been challenging for many people has been electronic health records. And you folks have alluded to it. And we're hearing silos, interoperability, and we're looking at the challenges of EHRs, and there's been a federal push to get people to use them. There was not a federal push to get us to use laparoscopy and minimally invasive procedures. So if you want to position mHealth to succeed, it needs to follow this route of the invasive side and what we learned in that, and less so on the infrastructure and the data side, which are still really plowing through right now. And so the question is for mHealth, and I also want to open it up for comments from the audience, is how do you view the data exchange in an mHealth era? Is it an interface with an EHR? We talked about a para-EHR that's popped up here. If you look at Twitter, text messages, emails, and phone calls, it's a para-EHR that disappears when you disconnect. Or is it a parallel track with mHealth where it'll be a combination of remote monitoring, patients texting in, to Twitter, communication, cell phone-based healthcare that parallels the EHR? So I'm curious how you see the data exchange and how this would interface with the EHR community. And open it up to the audience afterwards for questions and comments. So in our case, I mentioned early on the technology that we built and recently licensed over to Airstrip. The purpose of that technology was to develop a vendor-agnostic platform
that could mobilize EHR information coming from a variety of legacy EHR systems, provide that information in real time to the physician over a single common user experience and user interface that's agnostic of the back end. So the physician, again, along the theme of horizontal integration, the physician would only need to learn one UI and user experience, get comfortable with that on mobile devices, and then be presented with all the information that they need on a particular patient, that information being housed in a variety of back-end systems. The other piece that we brought into the fold was real-time physiological monitoring. So we think that's going to be very important in the future as you move into the home setting and you want to send patients home with monitoring equipment, sensor-based equipment. We think being able to monitor that information and present it out to the physician from the same user experience UI sort of paradigm is going to be very important. So that's where we initially focused, is on this area of horizontal integration and a single user experience for physicians in the community that we deal with. So the objective for us in terms of our mHealth sort of platform initially was to deliver physician happiness by taming complexity. Now, I don't know if we can ever make physicians happy nowadays because we've managed to make their lives miserable. Now, I don't know about the thing about you, of course, as a surgeon, you started with kind of taking this evolution and innovation in the surgery space, non-invasive sort of procedures. Not to get off topic, but the one area of interest for me is notes in surgery. So natural orifice surgery is a big thing to watch here in the future, and that's going to really, I think, disrupt what we're doing today. You're going to be able to send patients home much more quickly. So does everybody know what notes is all about? No. Okay. Do you want to?
By gaining access to the body has been, this is a little off topic here, so I'll keep this very
brief.
Well,
you brought it up, man. I'm just, okay, go ahead.
Gaining access to the body, we typically do through the external route. So we make holes in the skull, holes in the chest, holes in the belly, and holes in joints. And what they're trying to find are ways to get into the body that we already have. And there's only so many holes and openings that we have when you can use your imagination. But there's ways of getting in there and actually making holes in the organs that you enter. So you could go into the stomach, make a hole in the stomach, have camera head pops out, you pick up the appendix, you staple it off, you pull back out of the stomach, and you actually close the stomach intracorporeally and then pull out. So there's actually no incision on the belly wall whatsoever. And you'll see in the coming 2 to 5 years an enormous push towards looking at this technology and validating it. You'll see robotics. People will figure out if the robotic world is going to be successful across the procedure world, and you'll also see telementoring rise in the world of procedures. So procedures generate 40% of a hospital's revenue. They're an enormous risk from an IT standpoint, from a quality standpoint, from a cost standpoint, and you will see in mHealth that telementoring will soon emerge. But the one thing I think is interesting, what you said, Orlando, is that what you're advocating, or what I'm hearing you saying, is that there's going to be a Switzerland-like approach. You're going to try to be the FAA of Switzerland and coordinate everything and be agnostic, but you're going to see the rise of a para-EHR or a second system that's going to work with them and from them, but it's going to be different from the EHR, so that for the nurses and doctors and other folks in this room, one of the things that we hear as providers is that we get very used to our own workflow. It could be they hand you a chart, I use this pen, I sit at this table, I make this call, or I get into Epic, I know my structured notes, I know my nuance, I know how to close my note. And we see this second system arising, and how that second system works for us is going to be very important.
Yeah,
I'm supportive of that approach, by the way.
And you asked about the challenges, and they're obvious when you're dealing with a multi-vendor ecosystem. And to the degree that these vendors are opening up an API, if you will, to allow us to innovate around their platform. And some, as we know, are much better than others in that regard. What you're going to find today, the
that
big
was a euphemism.
Yeah, no kidding. Except for him, he built all his own stuff, so he controls. But one of the interesting aspects of this is that if you're looking to mobilize a legacy EHR, you're going to just go out and buy that vendor's mobile app. So it could be Haiku for Epic, for example. But if I'm, again, talking about horizontal integration, so what is a doctor faced with? I have information sitting in NextGen, sitting in Cerner, sitting in Epic. What do I need? 3 different flavors of mobile apps now? And that is going to be a nightmare.
I agree with you. We have 3 EHRs right now, and we've got a 4th one we've built in the middle.
Well, lucky you. I don't have 4. So it seems to me we're solving different kinds of problems, and we started around physician engagement, I think, in this discussion. The best engagement we've gotten from our clinicians or providers across the board hasn't necessarily been the great UI, although it helps, and I would agree. You need to have consistency to the degree you can get it. And it really hasn't been on how quickly, a lot of it is speed and reliability. But what it's been, where we've gotten engagement is when you can show that what you're doing is actually speeding up my practice, or what you're doing is actually curing that patient better. It's providing a higher quality of care. So they are getting better quicker because of the things your tools are providing to us. Then it's got value, and I'm going to get engaged. In fact, I'll do really unnatural things. It could be an ASCII-based screen, and I'll do it if I know those things are happening within my care. So the reason I bring that up
You're getting a lot of nodding in the audience, by the way.
Well, and what it brings together for me relative to the conversation about these I think you used the term
Paranormal or para-EHR?
Para-EHR. Data is so important. And if that data simply becomes a text, it becomes unusable in a form where it may be important, which might be a decision support protocol, or it might be in relation with some other clinical data that we do have. We have it within our system. But because we're using various forms to gather this and we're not taking the energy and time to bring it together, it's as good as a phone call, and it's not going to be useful to you in the future. So I think a very large part of engaging the clinicians or the providers or the payers or anyone involved in this stream is what value is this going to bring? Is that data going to bring? And are you spending the time right up front? Versus going out and buying every device or BYODing your own devices, are you spending the time on the back end for what you're actually going to use it for so that it has value in the long end? It looks like we have a question.
We're going to get a question, but it's interesting to hear the consensus amongst the panel, which is good, is that...
We agree. He just has a different eye.
Is that this is not an EHR-based industry, which we all know, and we agree. So mHealth is not a UI into an EHR, and that it's a whole nother world that goes far beyond just a series of screenshots or new interfaces, or we're hearing about monitoring, care coordination, and all these other aspects of healthcare, which is the reality, are here. So we'd love to hear your question. I'd like you to just identify yourself, where you're from, and are you from the provider space or a hospital space or a vendor space or whichever?
Chris Bickford, MD from La Jolla, California, with Scripps Health there, which is one of the big systems competing with Sharp Health, and Palomar Pomerano. and I'm also here not only as a private physician, but representing 3gdoctor.com, which is a new innovative system in England for video conferencing with patients, and they have every GP in the country potentially enabled with every patient in the country at their option as a separate from NHS private service.
Interesting.
Would like to know if the 3 different gentlemen on the stage representing very, very different systems have any knowledge. Your telementoring thing is something I hadn't even heard of before, and that seems like an application, but I don't know any system in the country that's using video conferencing with their patients, to minimize costs.
This is a great question, by the way, and I thank you for asking it. And I think one of the defining moments of mHealth, or the defining aspects of mHealth, is going to be how this relates to, is underneath, is beside, is above telemedicine or telehealth. And so when you started to get in the world of video, it makes mHealth be a very, very, very close relative, if not a direct relative, of telemedicine. So I think that video is an important part of mHealth, and it's a good question. So it's something for you folks to think about. And I'd like to get some comments from the audience a little bit later about the views of mHealth and telemedicine, because I think it's very, very important. But I'll turn it over to the panel about your thoughts about video and patients at home, and it's a fascinating question and topic.
Well, I certainly think it's going to play a huge role as we go to shared or accountable care organizations, and as we involve the patients more consistently through the whole care process. We're doing a little bit. We call it e-visit. Really, this is what we started about a year ago.
Are those video or non-video?
They're video, e-visits, and the technology is clearly early in some of the things that you really need to do. I mean, if you're going to make it a seamless process where a physician is in their clinic and they're caring for a person, and then their next visit, they don't go into another room, they go to a video monitor, and they do exactly the same type of thing. The technology is just starting to get to where we need it.
They basically said, no, Dr. Bickford, under no circumstances are you covered for online or video conference calling. They did say they had one client, not you're describing of your own organization. Do you know if you have legal authorization through your legal system to provide those services?
I know for the level of service we're providing, we're doing it within the bounds of our legal organization. And again, we are just getting started, and we're the largest single employer in the state of Utah. So we have a lot of patients that actually are employed.
Does it require a face-to-face, in-person consultation first?
I don't know the answer to that.
So we are covered in Pennsylvania. We're also an integrated system, and they tried to make it covered. They tried to make a face-to-face visit first, and we were able to successfully, what's a good word you can use? Not derail. That's a little bit challenging. Able to hold it off.
It's called derail.
Derail.
So the patient, physician, yeah, you have to establish that relationship. I think that's the same in Utah.
So let me make...
We don't have to in Pennsylvania, which is interesting, and also we are covered right now.
make a comment on the video space. We haven't met, so you had to come all the way out here so that we could meet, which is good. But I don't know that I would consider Scripps a competitor. I mean, we usually gain a lot more market share in our service area than you do, so I don't know that. It's a very good institution, by the way, so I don't want to slam them too much. But you may have seen some of the work we've done with Cisco in terms of integrating video conferencing capabilities into our mobile applications. And so what we've enabled, we've done a lot of prototyping work where the physician, for example, is looking at an electronic health record, some aspect of information that's housed in the record. They can pull up and query for the care team that's taking care of that patient. And then they can actually get a list of whether those caregivers are available by video conference in real time. And we provide that transparency, and then they can actually initiate in real time a video conference with that caregiver. So we've done a lot of prototyping in that area, as well as the notion of being able to enable patient to physician video conferencing as well. So in the home, the idea of having patients with a video-enabled sort of device, right, and being able to do care consultations as well. We've opened up retail clinics in grocery stores, and so in San Diego, Albertsons. And in that setting as well, we can video enable those sort of consults from the retail setting. Just a number of things that...
So to summarize, what we're hearing is that video is here, video is real, the cost is down to almost nothing. Certainly Skype and FaceTime, you know, Microsoft's now the largest telecommunications company in the world with the acquisition of Skype. So, and it's consumer grade, it's beyond that. And if you look at my 9-year-old daughter and 76-year-old uncle and mother, they all do things together on video. So it's almost boundless at this point, and it's cheap, and it's getting better, and the transport is here. So I think that in terms of physician practice, as a takeaway point, we'll try to make sure we leave some breadcrumbs throughout today. Video is here, video is real. DSLs are almost out, Fios is in, and then you're also seeing 4G technologies. They're getting the latency fairly well down on these technologies, to the point that you can actually do this. I'll be actually telerounding back to Pittsburgh on a wireless network in a few minutes after leaving here, and I've done it from around the world, and so that's a good example of how video works at all levels. And one last comment, if you speak to Adam Darkins from the VA, and we heard him speak at the Center for Connected Health, they're the largest telemedicine institution right now in the United States, largest one. They also rival in size the Ontario Telemedicine Network. They want to push about 20,000 video visits to the patient's home this year, which is an enormous volume. So it's the reality.
Are you aware of any system that's using either FaceTime or Skype officially? Are they considered HIPAA compliant?
Skype is HIPAA compliant. The issue is you have to lock down the directory because the directory is not HIPAA compliant. So the actual transport mechanism and interchange it's the directory, and you have to lock that down, is my understanding, and that's been our position.
That was one of the reasons that we looked at the Cisco infrastructure, unified communications infrastructure, and telepresence. That's a lockdown environment that can be controlled by the enterprise, and so if you're using that sort of technology and then pushing that out to your constituents, you're assured that you've got enterprise sort of quality services and security built in. FaceTime is right now its own world, as Apple likes to do. And Apple is, we hear, going to be opening up an API for FaceTime. I haven't seen it yet. I don't know if you guys have played with it, but we could write to that if they become standard sort of compliant.
And interesting to hear that, because, and I'll push back just a little bit, I find it, I'm also part of IT executive management for UPMC, and we're about $1.5 billion into our IT investment right now, which is increasing. And it's interesting, the approach. Do you take a centralized video control approach, or do you turn it the other direction, like what both of you alluded to earlier, and saying, well, let the consumers come in? And Intermountain's got a fascinating approach to this, or do you take a Skype, FaceTime, open the world and come into us approach with video? Okay.
Oh, we don't want the lawyers. You don't want the lawyers to come.
So next question, absolutely.
No, so we are developing, it's definitely a closed network. It's not open. We're not using Skype and all the other technologies that are out there. And we're being very cautious as we approach this space. Not so much from a legal HIPAA perspective. That has to happen. I mean, that's just a given. But how do we best provide the care? How do we best give an experience? How do you actually can take a referred video call, video interaction, and actually go ahead and transfer that to someone else seamlessly? And so those have been the kind of problems we've been working through, and why we haven't been able to just open it up to the world. One would hope, as we get more of that foundation structured, also what we're doing with that data, by the way, going back to my theme, then we can open it up more broadly. But we've seen in every instance, if you'll deal with those foundational issues, not just chase the world and then try and bring it in and figure out what to do, but you actually deal with the foundation, you can sprout out pretty quickly and do a lot of different types of things, and probably involve more of the Skype and FaceTime and those types of things.
So we're going to start with the front and move to the back for questions. So this is a good one. Videos, and the barriers to adoption are coming down. There are certainly concerns about it. There's a mechanical concern about handoffs and other sorts of issues, but it's in.
So if I stand here long enough, my comment will have no relevance.
That was our intention.
Yes, I know. Alan Portela, Airstrip Technologies, and by the way, Mark, cool tie, and Orlando, where's your tie? Anyway, so I have some comments, not a question, and it's more about the previous discussions that we had around EMR consolidation and also going into video conferencing and all other care coordination tools. You were talking about your example of having 3 EMRs, EHRs, and moving into a 4th one. What happens in the next 5 years, we're going to have probably 50 healthcare organizations that are going to own every hospital. So the idea of one EMR dominating one healthcare system is not going to be there anymore. So as you acquire more healthcare organizations, more hospitals, more post-acute environments, you're going to have a huge amount of systems. So the idea of what Orlando is doing, which by the way, it's a great idea, and that's why we decided to work with them. So I use their technology, and I'm a patient here of Scripps. I live in La Jolla also, so we're all here from La Jolla today. So what happens is, if you look at being able to commoditize the EMRs and the EHRs. We did it before on the patient monitoring side. Now physicians can look at data regardless if you have GE, Philips, Siemens behind the scenes. All what we need to do is to start mobilizing the most important clinical data sources. And you start with medical devices, then you go with EMRs, and then you're going to look at other things like video conferencing, secure messaging, etc. We have to realize, as we see that physicians are becoming more specialists, the hospitalists, less primary care doctors, we need to improve care coordination, and physicians are becoming mobile professionals. You need to take the data to them wherever they are, rather than them going to a desktop to interact with a computer. So if you look at telemedicine and mHealth, well, mHealth is the vehicle to deliver telemedicine, so it's not two different things.
Interesting. One thing I would just beg everybody in the audience is to use the word provider as much as possible, because it really is this amazing process of nurse and doctor. And to be honest, the doctors are the Luddites right now. We are the ones that are holding this back. It's not the nurses. And so I commend the nursing field without any reservation whatsoever for leading the doctors on this one and being more open-minded than we have, because, my Lord, we've given them a lot of technology and they've succeeded. So, but thank you for your comments, and it's interesting to hear you say that, and I think that I personally agree you can have many, many EHRs, and if you want to have any follow-up comments to his.
I think you bring up an interesting trend, right? So we're going to see a lot of consolidation. We're going to see, in my opinion, in the next 36 months, smaller, mid-sized, standalone hospital organizations are either going to go out of business or get acquired. Many of them are going to go the way of the Twinkie, and it's going to be lights out for them.
Brings a tear to our eyes.
Unless they start to address care coordination and start to look at being more tightly integrated with other providers in their region. But as they do that, they're going to be challenged with this sort of multiple EMR integration problem that we've been talking about, and I think mobility is an enabler for addressing that.
Yeah, I think I absolutely believe the trends are right that you outlined, and the challenge of multiple EMRs is going to be real. But I don't think our role has to be in the whole, not just care coordination, but that's incredibly important as well. But it's got to be around getting some consistency and ability to provide more or less variable care, so more sameness in care across whatever areas that we're doing. So I do have concerns about mHealth and about all the different devices and applications and programs that are getting there or coming out if we don't define some standards. And I don't think that's going to happen, by the way, necessarily by the industry or by the federal government. But particularly in the case of mHealth, we're going to have our own standard across Intermountain Healthcare. This is what it's going to mean if you have a mobile device. This is what it's going to mean if you're going to use telehealth or video. And these are the tools, and we'll provide those tools. And as the CIO with the information system requirement that I have, not just innovation, or not innovation, whatever. We're going to be very concerned that we put the appropriate standards in place, that we don't have to go to 50 EMRs or para-EMRs, that what we have, an EMR has a function, as does a nurse assessment tool, but they don't have to be different data. They're different functions. And I really think it's going to be important if we want to manage these economies that are going to come out. If we have to have IS departments that consume 12% of operating operating costs, we're going to put everybody out of business. We've got to be running around 4 to 5% to even make it a business that's someone can continue to use. So I just really think it's exciting. It's wonderful technology. We have a booth downstairs, which I would never think you'd see from Intermountain Healthcare, the most conservative organization in the world. But you're going to see we're really excited about the technologies. But underlying every conversation, don't just let it go. Don't just let it get out there and get out of control, because if it does, we'll pay for it. We'll pay for it on the back end.
I think we're in the back now, the gentleman with the blue shirt on.
This is Santosh Kumar from University of Memphis. My perspective is that of a mobile health technology researcher. I'm a computer science professor. On the incorporation of mobile health into the healthcare system and how it might be adopted, Mobile health is pretty exciting. It provides enormous amounts of data and data that we have never seen. But there lies the challenge too. If we just throw all that terabytes of data to the doctors or nurses who are already overburdened, then I don't think that's going to work. If we throw at them decisions from this data that has not been carefully processed, there we have another problem of the liability. So I think the adoption of mobile health, given its enormous capability, isn't going to be that easy or that quick. There are several narrow paths out, and once we are able to establish them, that might help enhance its adoption. So I see two, actually. So one, that means if we use mobile health technology to look at or detect something that we have not been able to address in the traditional healthcare setting. So some condition, let's say congestion in the heart failure, that we have not been able to observe because it requires lots of efforts in the hospital, and we still can't get it. So in those cases, everyone around the table, whether it's the doctors or the nurses or the patient, they all can rally around it, and they will be able to get past this hurdle of this big data and having the challenge of looking at the data and making the right amount of information. The second is having the right amount of intelligence from the data. That means not requiring lots of people be available 24/7 to look at the data, and once they see something, then pass it on to the doctors, but rather the system itself having the right amount of intelligence to be able to make the decisions that both doctors and patients and their caretakers can trust. So those are just some comments, but I would love to hear any further comments on this. Thank you.
I find it interesting the way this is the gravitational pull of data we're hearing here and out there, and big data is certainly in vogue right now, and how this is affecting the discussions.
So I couldn't agree with you any more. The complexities of healthcare, the number of decisions that are being made by clinicians, and just this vast array of data that's available to people is just increasing the variability issue around healthcare, because it's impossible for us to ask clinicians to be consistently coming up with the same consent or diagnosis when they're looking at so much data and so many data points. So the key, though, again, is understanding what you're trying to do with any technology. Video is a tool. A handheld device is a tool. Just like a PC and a server are tools, it's how you're going to architect those tools to work with each other to solve whatever problem it is you're trying to solve. I said it earlier, in healthcare, particularly in IT, and particularly the way EMRs have grown up, we've tried to solve every problem with one system, and didn't even look at data consistently when we built those EMRs. The challenge is going to be defining within your organizations, because again, I don't think anyone's going to do it for you, many of the standards around the data that you need, and then how are you going to use all these tools to solve problems, keeping in mind what you have to keep solid is that infrastructure. And I say the same thing.
Yeah, I would say to innovate in the area that gentleman just talked about means that you need to wrap around and innovate around the electronic filing cabinet, which is a pretty dumb sort of vendor system in general. So you've spent all this money on an EHR system that captures information electronically. It does have some workflow components for basic order entry, results viewing, et cetera, ADT, scheduling. And now we need to innovate around these EHRs. And if you could think of these EHRs as a black box, basically, that you innovate around in terms of the knowledge management enablement that he spoke about, predictive analytics that wrap around the information that's being collected. The other large data set we haven't talked about yet is genomics, of course, and what that means for offering physicians some predictive capabilities and how to deal with those data sets and represent that information. There's some work we've been doing to mobilize viewing genetic information in a very easy to understand way for physicians on mobile devices. That's another emerging area, I think, that we're going to need to look at.
Okay. So I just want to politely disagree that I think there is so much variability in healthcare right now. I'm speaking now as a doctor, if nothing else, that it is extremely alarming and that the big data will show this. I don't think we're seeing enough data. I don't think I'm seeing nearly enough data. I would say as a physician, as a surgeon, that I'm seeing about 20% what I actually need to see. So I view mHealth as the natural evolution of healthcare. There's a reason why people are adopting this. No one took a horse to work, and no one bought a roll of stamps in the last couple of weeks, or maybe you did, I haven't. And so this whole industry is evolving in a very natural way towards the patients. And as the questions move forward, one thing I want to focus on, and if the questions that are coming in too, is that we represent extremely large healthcare systems in the United States. But the vast majority of healthcare is delivered in practices with 10 or less providers in them. So as we frame questions and issues, I think we need to bring this back also to the small practice groups who really are the bread and butter of healthcare in America. And if you look at where reform is going, we need to get care back and support care in that location. So one of the barriers to adoption is making this affordable and integrated to the smaller practice groups, of which we're all devouring as institutions up here. But how do we give care back to them through mHealth and empower those physician groups as well and nursing groups as well? So I'll give it back to the audience with that in mind. So next question will be in the front of the room.
Thank you. My name is Eduardo Garcia. I'm from Miami, and I'm a contributor with the Huffington Post. And Dr. Watson, right?
Yes.
You had mentioned earlier that clinicians were very used to their workflows a certain way, and they don't want to necessarily have to deal with much change in that area. And Orlando, is that right? You had said that you view mobility as an enabler of integration of different health information systems. So I wanted for you guys to elaborate a little bit on the transition of the culture of the physicians. And I really want a frank answer, an honest answer. Is that culture really changing? How is it changing? Where do you see it going? And is it going to really allow for innovation, especially with the smaller, like you mentioned, the smaller practices, but most importantly, smaller guys in entrepreneurship, startups? You know, is the country club really going to open up to these smaller guys that, you know, really want to make an impact? Thanks.
I've never golfed in my entire life. I've never golfed in my entire life. Let's put that disclaimer up there. Good question, though.
Well, give my regards to Ariana. So let me see. You asked a ton of questions there, all wrapped up. I'm trying to figure out what you're trying to elicit there. So, and notice how he passed the mic to me because, well, for physicians, they're going to be financially challenged here going forward. The small groups.
There goes our country club.
Yeah, forget that. I mean, so the, you know, mom and pop sort of physician practices, those are going away. Those are going to get acquired. They're going to be forced to integrate with a larger system to get more tightly affiliated with the larger healthcare provider organizations in their region. To that extent, they could potentially leverage the technology investments that these organizations have made and start to tie in more closely with that. And what were some of the other things? You said something about, you asked about the vendors or an entrepreneur?
You had mentioned that mHealth was the enabler, and Dr. Watson had said that the clinicians were used to their sort of traditional workflows. And is the culture going to change? How is it going to change? One. And two, how is the market going to open up to smaller innovators?
So for those that don't go out of business as a result of Obamacare, you can print that. They are going to need to embrace technology much more than they have in the past. They're going to need to embrace care collaboration processes where they exchange information with other providers across organizational boundaries. They're going to need to address preventing readmission rates on the hospital side, dealing with transitions of care. So when you come out of a hospital, we're going to need to automate the process by which you engage back in the community with your primary care physician and be able to more freely exchange information across those organizational boundaries. So for those that do stay in business, I think we're going to have a greater degree of collaboration across the healthcare value chain.
So you asked about the providers and what'd you say, transition of culture. I don't think providers are resistant to change. And in fact, they learn all the time. They're finding new ways to provide care better. Some people are less willing to change and more resistant than others. But I mean, crap, my VCR still flashes 12, and and my clocks don't always change on daylight savings time. Thankfully, we bought, or someone made a clock that would actually change automatically at daylight savings time. We need to be thinking about our technology in that way. It isn't that it's that there isn't a willingness to change. It's we're putting just unbelievable amount of change on these providers, and not in every instance are we thinking about how we can deploy some of these technologies to make it simple. I have yet to meet a provider, and I'm sure they exist, but I've yet to meet one that doesn't want to provide the very best care for that patient and wouldn't use the very best tools. But we do make it extremely difficult. It is a complex process, healthcare delivery. We are throwing new technologies at these providers at an unprecedented rate. We're not generally giving them all the training that they need to do that. We're saying, here's a tool, go have fun with it. I just don't think there's a huge resistance to change. There's just so much. And we as technologists and people that lead in technology need to be thinking a couple of steps ahead and providing things that could be useful to whether it's a single doc in Miami or whether it's a 100-group practice in New York City. It doesn't matter. If it's intuitive, it's intuitive. It's just the scope of the training we might have to provide. But I don't think there's a lot of resistance to change. There's just a lot of change.
I would take the contrapositive that I think there's enormous resistance to change. And I love being a doctor, and I love my peers. My wife's a doctor. Her parents are doctors. I mean, just go down the tree, and it's. So I did something different, was a doctor, and it's amazing how much energy providers, nurses, and doctors put into this profession. But I will say, as a whole, the provider community is enormously resistant to change right now.
How many of your docs have iPhones?
Most of them.
Okay. They changed.
The interesting part is the currency for healthcare that we use was invented by Hippocrates in 400 BC. When he invented it, he was put in jail, by the way, because he separated disease, religion, and superstition. So for 20 years, he was in jail on the island of Koa, where he actually did most of his writings. And so the currency for healthcare up to today is a face-to-face visit. And it's amazing how that currency persists, and the resistance to breaking the face-to-face visit is shocking. I see preoperative visits, I meet them with video, I operate on them, and all their post-op is done in video. So there's patients that I touch right now I've actually never met face-to-face, and you're viewed as having a dorsal fin or 3 legs or carrying a spear or having scales. And if you ask the patients, they love it. And I have about 40% of my practice in the cloud, and that's not enough. At around 70%, I think it's going to work efficiently. And so I find the provider community as a whole is extremely resistant to change. And I don't view this as our problem. It's a byproduct of where we've been. I think the national professional organizations aren't leading us through change successfully. And I also think that the stress on us is so much that we don't know how to handle change. We're not taught change. Other industries would bring up a parallel product, tear down the old one, and keep going. We keep renovating the old economic model, which is not successful. And furthermore, we're given systems right now that are challenging. And UPMC, I commend them for their efforts to try to bring interoperability and to simplify IT, because one EHR vendor gives me 69 icons on the home screen. The other one has 71 icons on the home screen. I get EHR views, newborn growth charts, labor and delivery views, and pediatric growth charts in my EHR. And I also get tympanic membrane drawing ability right below vital signs. And if you click into that, you have to draw a tympanic membrane. You can't exit out of that. So it's a real challenge for us, yes, on the IT side, but I think as a culture, as an industry, we have to realize that the days of the doctor-driven country club era are over. I have enormous respect for my peers, for our leadership, my own organization, but as an industry, we have to change. And for me to get a conference on telemedicine in the American College of Surgeons has been impossible. I got one done and got shut down this year. And surgeons are the ultimate consumers of video. So the industry needs to adapt. It's going to be hard. It's going to be hard. I give Atul Gawande immense credit for having the courage to write about this in the New Yorker in his book. So it takes a lot of courage what he's done to actually say it. And this is just the tip of the iceberg. Prostate cancer was the other breast cancer.
How many years do you think it's going to take for the if you had to put it on 10 years, 20 years?
No, I think it's in the next 2 to 5 years. And I don't think it's Obamacare, Romney care. I think it's for broke care, we're screwed care, what the hell happened care. So pick your moniker. But that's going to force the issue. I like the more broke care is probably the best way to, most politically correct.
So legislation driving.
No, I think it's going to be a very organic process that once the healthcare industry starts to get surfaced more and people look at it with less of a prismatic lens and less of a sense of entitlement, you'll see the change. In September, the Institute of Medicine's alluded to the fact that we waste $900 billion. The error as human really didn't change us all that much. I mean, overall, our end results. So when these sorts of things bubble up, I think you'll see across the country more of a lens on who's good, who's not good, getting video into your doctors, having very sophisticated innovation officers working with teams of people to understand this. So you're looking at two national leaders right here, and I give Eric credit for finding them too and working with them because it's a very interesting time for us. So a lot of respect for these people up here. So I think we're in the back of the room. Here we are, yes.
Hello, my name is Ann Giles Cleland. I'm the founder of Handshake Media Incorporated. I'm one of the guys and gals who are entrepreneurial out there in the health industry. We have a mobile health behavioral application that we have finally gotten a pilot study for. I'm going to speak during the extraordinary mHealth app session on Wednesday, and I'm going to be addressing the entrepreneurial clinicians and providers in the room, and I am very open to hearing 3 suggestions from you to share with them, pass it forward, CITI, OSP, IRB, just about to kill my little startup here as I am, trying to it must be tested. I understand my app must be tested. It can't be a home remedy. There has to be data proven, evidence-based. So help me help them because I understand in-house innovation, but I heard you say you're open to doing abnormal things if patients get better quicker. And so it might be a little abnormal to pair with an entrepreneurial startup who has a mobile health application, but maybe you'd be open to it because I bet everyone in this room has a great idea.
So you're in the behavioral health space?
Yes.
Yep. Well, that's not to throw a wet blanket on what you're doing, but
You can't.
that's an area that we're going to see, at least in the short term, underfunded as a result of some of the legislation. I think that we're going to see money pulled from that area, and it's going to be an interesting challenge of how we deal with that from a health systems perspective. IRBs, now you don't have, you're not fortunate enough to have the FDA down your back at this point.
Not yet, no.
Oh, well then you're lucky. So,
Yeah.
IRBs, that's something we do all the time, right? Engaging with healthcare systems on doing IRBs and research studies, so you should really have no issues. It may be an issue dealing with the appropriate organization that is a
Gatekeeper in the organization, I guess.
well, you've got to deal as a startup, you've got to deal with a healthcare organization, provider organization that is accustomed to being a very, very early adopter and has sort of that mindset and a process in place to engage with. You don't want to go into a sort of a traditional brain-dead hospital system that's almost going out of business with a 0.5% margin because you're not going to get anywhere as a startup.
Great.
So you do need to engage with some of the more innovative organizations in terms of doing that initially.
We've created something called the Innovation Lab at Intermountain Healthcare for specifically this purpose. A lot of it comes internally generated, and then we go create the technology, but some of it comes from partner or outside organizations, startup kind of organizations. So, and what that just allows us to do is to look at these technologies in a controlled environment, but bring actual clinicians in to test it and use it, so that we don't have some of the problems that might occur if you try to just put it into a unit in a hospital. But that's specifically how we're going at it, and realize there's great ideas out there. They're really good ideas.
We did the same thing at UPMC, where we have
We actually copied it from UPMC.
Fair enough. We have a technology development center. We have 60 full-time staff. We have, I think it's 40,000 square feet, where it's an entire location, where we have our industrial relations housed there. All of our partnerships are there. And we bring industry providers and then GUI experts, design experts, business planners, and strategists all together under one roof. And we work in collaboration trying to figure out how to make this better. In terms of advice, I would just make sure that when you have pilots, make sure that people are on board up front. And make sure you get the patient feedback. It's mission critical. Because when you're trying to break down some barriers, the patients will speak loudly for you. A couple of good patient wins are absolutely invaluable.
Good. Thank you very much.
We only have about 3 or 4 more minutes, unfortunately. So I think that we want to have, if it's okay, one more question, then some summary comments, and then some of us will be around later, but if that's okay, sir, we'd love to hear what you're saying there.
Sure.
I apologize to everybody else. My sincere apologies. Yes.
Josh Cohen. I'm a professor of medicine at the George Washington University Medical Center here. And so this morning I've been characterized as being a Luddite who is highly resistant to change. And I find that puzzling because, in fact, traditionally medicine has been a field which has been highly open and, in fact, highly responsive and early adapters to technological change. So I don't think that you can get by simply saying that this is something that is kind of programmed into physicians or other care providers from say, medical school onward, or whatever the case may be. I mean, there clearly are issues in the way that IT developments have been presented within the medical community that have raised tremendous barriers to their adoption. And it's not really on the provider side of things. So I'd just like to make a couple of comments on, I think, some of the factors that are important here. The first is, despite how hard it is, I think clinical outcome studies are going to be critical. I mean, at some point, very, very soon, it is going to be necessary to have really hard data showing that people are doing better with whatever it is, whatever application or system solution or whatever. And in the absence of that, there's really not a lot of credibility. That's the first thing. The second thing I'd like to mention is that I think that one should keep in mind that there are many different medical practice environments, and in particular, the medical practice environment in a hospital setting is going to be very different than the medical practice environment in an outpatient setting. And if IT solutions are driven primarily by hospitals as the major players in town because they're owning the practices and things, what you're going to find is that these solutions are not going to work very well in a outpatient environment, which is where a lot of the kind of care that we're focusing on going forward in terms of preventive care, health maintenance, is going to take place. The third thing that I'd like to mention is that I think that workflow is critical. We have been involved in a project recently in integrating a diabetes healthcare app into our outpatient electronic record system. And we've been doing this on a multidisciplinary basis, but what we found right from the beginning was that understanding the workflow that people had and designing systems that would enhance workflow, not simply be different, were really critical to getting the engagement and buy-in that is going to be required. And finally, as a corollary, I would add that in terms of training, you know, at the end of the day, nobody likes training. And so the trick is going to be to have systems that are as intuitive to operate as possible, that really require the minimal amount of training.
Like the
that's
iPhone?
all people are going to sit for. With that, I'll finish and let you folks comment. Thank you.
It's very well stated. And just and I'm willing to keep this discussion alive, when I talk about physicians being reluctant or difficult with change, it's a very hard conversation, and I get criticized nonstop for getting in front of my peers and saying this. It's very interesting, but the fee-for-service environment has made it very challenging. And look at the head of the American Cancer Association when they talked about prostate cancer, the front page of the New York Times, they were duking it out, calling each other stupid and idiots. Fascinating. So it's a very challenging time, and we are amazingly able to adapt on one side, but not so much on the other side, and fee-for-service is a very, very, very challenging situation that I think that will be de-emphasized moving forward. But we only have a few more minutes, and I'd like to make just a few summary comments and turn it over to the two panelists to finish up, because that's who you're here to see. But if you talk about engagement, which is one of the objectives, what you're hearing about is engagement is going to come through, we believe, and the position of this panel is not an EHR-based modality, but through a second layer or a second avenue, and probably a more powerful avenue, which you heard at the end, which is more focused on a workflow, it's easier to use, much like the fact that a piece of glass with a single button you could touch brought down BlackBerry. And you'll also see video and data as big parts of engagement, and also the barriers to adoption. And I think the warning that you've heard about engagement is watch out for data. Who owns it? Where is it? How is it organized? How is it communicated? And how can you react to it? And then the second objective was to talk about how you bring it into physician practices or provider practices. And clearly it's cultural change, care coordination, screening, preventative well care. It's all the modalities of the transformation of healthcare that we're seeing right now. Innovation is a big part of that. And then when you talk about reliable outcomes, standards are going to be critical, along with looking at best practices and also comparative effectiveness research. And we're already starting to see this in some avenues in the country. So those summary comments, I'll turn it over to the panelists, and then I think some of us will be available later on for some questions and ongoing comments.
I didn't really have a whole lot to wrap up with. I would encourage the healthcare organizations to spin up some capability to experiment and innovate and carve out resources where you can engage with startup companies that are innovating in the mobile space and other areas, and bring those companies to the table and experiment and try things out. And we like to say if we're going to fail, we'll fail early and small as opposed to late and large. So bring something in and test it out and collaborate with industry. There's a lot of small innovative companies at this conference that you can engage with and collaborate with. So that would be my takeaway in terms of this whole space. We're really at the very beginning of this whole era in mobile health, and as represented here by the number of small startups being invested in. So it's early in the game, and I would encourage healthcare systems to really start to engage with those smaller companies right now.
Great. And I would just say that, IS is absolutely a team sport. It used to be that there could be some nerds sitting in the basement of the hospital that could come out with some tools that could be used within the organization, and that would suffice. The knowledge around what these systems can do now exists in physicians and nurses and respiratory therapists, in people that collect in the revenue cycle organization. It exists everywhere, and we have to act as a team. As an IS leader, I think it's imperative that we architect what we're going to do, that we don't just bring in a bunch of parts and then say we're going to come up with a solution, but that we really start thinking about our plans on what we're going to do with our data and these systems, how we're going to secure them, and all of these things as we look forward. And if we do, we're going to create some pretty tremendous solutions for our patients and for the people that use our systems within our organizations. So thanks.
Well, thank you to Eric quickly for bringing us together with mHIMSS.org, and also to our two speakers here, and to all of you for the great questions. Thank you very much. Pleasure meeting